Good afternoon, everyone. Welcome to FAIR's free monthly webinar series. My name is Carrie Molkowski. I am the National Program Senior Manager here at FAIR, and I am delighted to be your moderator for today's presentation. So today's webinar, Early Allergen Introduction to Decrease Food Allergy Risk, will discuss the recent landmark studies and guidelines that are changing the landscape and the way that we think about early food introduction. So just before we get started, a couple things to note. This presentation will be recorded and posted on the FAIR website in about 7 to 10 days. Please note that for maintaining a quality recording, all attendees will be muted throughout the webinar. However, if you are having any technical difficulties, you can use the questions and chat features that you see in the GoToWebinar toolbar that's on the right-hand side of your screen. Also, you can use this feature to ask questions throughout the presentation at any time. You can just, send them through the chat feature. And then at the end of the presentation, if we have some time, we will respond to some moderated questions for our presenters. And then lastly, for those of you who are on Twitter, we encourage you to join us in conversation during the broadcast. You can follow along with us at our handle @foodallergy and using the hashtag FairWebinar. All right, so today's FAIR webinar is powered by Ready Set Food, and we greatly thank them for their support for this. But also please know that while FAIR does not endorse products, we support and appreciate enterprises and organizations that are committed to serving the food allergy community. FAIR's ability to make an impact is really strengthened by partnering with like-minded companies to help raise food allergy awareness and provide more options to all of those living with food allergy. This is just a quick disclaimer that I won't run through. And then the best part, without further ado, I'm delighted to introduce today's presenters, Dr. Jonathan Spergel and Dr. Katie Marks-Cogan. So first up, we have Dr. Spergel. He received his medical and graduate education at the Mount Sinai School of Medicine and completed his pediatric residency at Yale New Haven Hospital. His clinical and postgraduate research training in allergy and immunology were completed at Children's Hospital, Harvard Medical School, in Boston, Massachusetts. Dr. Spergel is board certified in pediatrics and allergy immunology. He is currently chief of the allergy section at the Children's Hospital of Philadelphia. Presenting alongside Dr. Spergel is Dr. Katie Marks-Cogan, who is board certified in allergy, immunology, and internal medicine, and treats both pediatric and adult patients. Originally from Cleveland, Ohio, she received her MD with honors from the University of Maryland School of Medicine. She then completed her residency in internal medicine at Northwestern and fellowship in allergy immunology at the prestigious University of Pennsylvania and Children's Hospital of Pennsylvania, commonly referred to as CHOP. After finishing training, she moved to Southern California and currently works in private practice. She is a member of the Scientific Advisory Board for Ready Set Food. And so at this time, I am very delighted to turn the presentation over to Dr. Spergel to kick us off.
Thank you. I'm happy to be here and happy for FAIR to invite me to speak about food allergy and food allergy prevention. Waiting, technical problem here for 1 second. I'm having trouble advancing the slide. Oh, there we go. Oops, I apologize for that. So we're really going to talk about a few things. We're going to go over current food allergy and recent trends, our understanding of preventions, and then we'll talk about early introduction, changes in the practice guidelines from the various academies, and issues with compliance and implementation. Food allergy, as probably you all know, as you are parents or members of or individuals with food allergy, have really increased over the last 2 decades. It's really been a dramatic increase. Food allergies back 60, 70 years ago were really rare, and people didn't know anyone. When I'm in my 50s, and in my high school, I really didn't know anyone with food allergies. maybe one person, but it was pretty rare. But now in an average elementary school class, there's about 2 kids per elementary school class. It's relatively common. There's been this dramatic increase now with about a prevalence rate of about 8%, as you can see in the slide. And peanut allergy in particular has basically tripled over the last several decades. And when we think about food allergies, still, strategies really haven't changed. It's still avoidance. There is epinephrine for treatment of emergent reactions. And then there's immunotherapy. And the goal of immunotherapy is important to realize this is not truly a cure. It is to desensitize you, to make you safe from an accidental exposure. It's not the oral immunotherapy, including the one that hopefully will be approved by the FDA shortly. It's not for you to go home and eat a bag of peanuts. It's for you to go home and have an accidental exposure and not have a life-threatening reaction. So we don't have a cure. We're really looking for, ideally what we always want to do in medicine is to prevent. So we're really going to talk about prevention strategies and how we can prevent things from happening in the future. When we think about food allergies, it is, as I said before, really common. And it's about 8% of patients. It's much more common in young children. And then we know also, we used to think people were allergic to one food, but now we know probably a little less than half are allergic to multiple foods. And foods tend to go together. Typically, it's peanuts and tree nuts. As I'm sure almost everyone knows, peanut is not a nut, but it does cross-react with some of the nuts. And then this creates the other big problem. When we think about testing for peanuts and tree nuts, you get a fair amount of false positives on testing that people think they're truly allergic and they're not, so they avoid it. And as they avoid it, they may actually make themselves more allergic because you need to eat the food and sort of make your body get used to it. And the other big issue is people are confused about food allergies. The study from Ruchi Gupta, which are the numbers you see here on the slide, shows just under 20% of people report they have a food allergic emergency reaction every year. Many of these reactions, unfortunately, are not really food allergic, but these patients are still going to the ERs, which creates a high level of anxiety. People think that if they're around peanut, or I'm having highs for a week because my kid was in the same classroom with someone who had milk, that's an allergic reaction. Or I think I had a cross-contamination a week ago and now I'm having highs. Your food allergic reactions occur pretty quickly, and they occur quickly within seconds to hours after eating the food, and they tend to resolve pretty quickly. So if something's having a reaction lasting a week, it's probably not a food allergy. So, these are numbers that patients report. If you actually look at what physicians say, they're about a quarter of that, which is still about 5%, which is still a lot. And this lifetime emergency room visits, about 40% is not, it's probably close to being right, because most people on that first time they have an allergic reaction end up in an emergency room. And unfortunately, only 40% have an epinephrine device. We need that needs to be higher. People need one, and that's a whole separate other issue, but we need to have it. When we think of peanut and milk, those are by far the 2 most common ones in children. Then you have shellfish and nuts and eggs following closely behind. Interestingly, one that's not part of the top 8 but does show up next is wheat and soy and sesame seed. Sesame seed shows up as the top 8, the new top 8 allergens, and wheat and soy are falling off, which is an interesting issue because sesame seed is not labeled at the current time, and patients who have sesame seed allergy need to be extra vigilant because it's very hard to avoid. And when we think about avoiding, it is hard. Some things are much easier. It's relatively easy to avoid shellfish and fish. They're pretty obvious things to eat. But milk and egg are in everything. We've never heard of a milk-free school or an egg-free school, right? And milk is actually, interestingly, the most common cause of reactions at school. And we don't recommend a milk-free school or a peanut-free school. That's unrealistic. We don't want our patients to live in bubbles. We learn to have them live with a good quality of life and learn that they can be around the food. They just can't eat it. Peanuts is by far the most feared, followed by the nuts, and that's probably because they are less likely to outgrow and have some of the highest rate of severe reactions. Interestingly, milk causes a lot more causes fatalities in the young children, but peanuts and nuts and shellfish are the ones that cause the rare fatalities in adults and in teenagers. People really, unfortunately, still don't know what need to do. This still has a major impact on families, and there's also still issues of bullying. I mean, there was not that long ago that Disney movie where they were throwing their food allergic food at him to bully him. That's a problem. So we really need to work on that and have that issue. And it also still is a major cost, and the estimated cost is about just over $4,000 annually per patient for just taking care of medical care. And that includes things like office visits and allergy testing and changes in your diet. So when we think about who's at risk for food allergy, why it has risen so much, there are several reasons. One is family history is a risk factor. It's not everyone with food allergy has a family member, right? And sometimes it's a new one. We know male people are more likely to get food allergies compared to female patients. Patients with atopic dermatitis are more likely to get it. And so, but the other big issue with atopic dermatitis, not every patient with atopic dermatitis has food allergies. Actually, it's actually pretty low. Most patients with atopic dermatitis don't have food allergies. For the patients with severe atopic dermatitis, maybe it's a third, but with mild, it's maybe 5%, which is similar to what is normally out there. So it's really the moderate to severe ones have that increased risk. And we worry about why atopic dermatitis is a risk factor is due to the fact that when you have active eczema and that active lesions actually acts as a great way to make you sensitized. If you put a food on an area of active lesions, you'll make the highest level of IgE. It makes you very sensitized. And we were able to, many years ago, show that in the mice. The other thing is that people worry about the siblings. And interestingly, siblings are an increased risk. As you can see, it's about 13%. It's higher than the normal one, which is now 5 to 8%, so it's higher. But it's not huge, so most siblings are not allergic, but there is an increased risk. People always ask why things are going up. The answer is we don't know, right? There is this issue of long time to introduction. That's the dual allergen exposure that we need to eat it instead of wear the food. Avoidance, we gave really bad medical advice 20 years ago, telling people not to eat the food. We need to go back to what we ate 80 years ago and how we ate things 80 years ago, where it was less avoidance and more better exposure. And that raises also the hygiene hypothesis, where we too much antibiotics and too much detergents and soaps and things that were too clean, and that being clean, whether changing the microbiome by all the antibiotics or using soap that's destroying the bacteria that lives in our gut, or changing the bacteria that the soap that we wear in detergents is breaking down the fats on your skin, makes you more likely to be exposed to things, also increases your allergy risk. The other one people like to talk about, vitamin D, and that one's beginning actually, interestingly, to fade out. There's several vitamin D studies that have been recently been done that don't look so promising. Vitamin D, truly interestingly, is a seasonal disorder. If you check people's vitamin D levels here in the Northeast, in the wintertime, everyone will be deficient, but you check it in the summertime, it's not. In California, where Katie is, people are less vitamin D deficient, but if they wear too much sun lotion, they are. So it's probably not really a main player that we think of at the current time. So what has not been shown to reduce the risk of developing food allergies? Changing maternal diet does not make a difference. Changing what's in the breast milk does not really show much difference at all. Avoidance of allergens has not been successful. There's never really been any good study that shows avoidance works. So that was sort of bad advice that the medical community gave at one point. The hydrolyzed infant formulas, whether using the extensively hydrolyzed or the elemental formulas, do not look very promising. There's some studies that suggest there's some benefit in one, but it's not consistent from study to study, so it may work on a certain population which we cannot yet define. For prebiotics and probiotics and vitamin D, as I mentioned before, vitamin D does not look very encouraging. Moisturizers, there are 2 large-scale moisturized studies that have just been completed, and the data will be reported shortly, so we'll find out if that works. Prebiotics and probiotics are very mixed. In the initial studies out of Finland, they looked really promising, especially for the first 2 years of life. After that, the studies really, everything seems to normalize. They've not been able to replicate it in lots of other places. Again, we sort of need to know that when we think about microbiome and a lot of these other issues, there's going to be a personalized story. What may work in one culture may not work in another, and that depends probably on your microbiome, what's around you, what other early foods you're adding into your diet, your genetics, as well as other elements. So this idea of allergen exposure is that we need to begin to expose the body the normal way. And when we know that chronic oral exposure, whether in mice or in humans, probably leads to tolerance. When you expose a human through the skin, which is the work that Gideon Lack showed, or through a mouse skin, which is what I showed over 20 years ago, you can actually sensitize a person. You can make the highest levels of IgE. The skin was the best way to make someone highly allergic, better than any other way that you can do. And you really need to do this. And this is an important way of, when we think about it, that's why we think about maybe better moisturizers, controlling their atopic dermatitis, and getting people to eat the food, because we really want people to be exposed to the normal way, which is through your gut. And we expose whether you do this in mice or in humans, that chronic exposure early on will lead to make people tolerant and not allergic. So as we think about doing early introductions and what's that found, and this was the originally work done by Gideon Lack, and they made this observation that the rate of peanut allergy in Israel was actually much lower than the rate of peanut allergy in the United Kingdom. Then they looked at basically a similar population to hopefully control for the genetics. They looked at the Ashkenazic Jews, which is in these two populations. And what they found was that in Israel, the people ate a lot more peanut compared to the United Kingdom. And it was the fact they were giving a certain teether, a teething cracker that had peanut protein in it. And the thought was that the that teething cracker actually might prevent that would make people less allergic. And this raised the idea that early oral exposure might be protective against food allergy. The question was, this is a severe issue? Did this lead to problems at all? And when we looked at the studies from the Gideon Lack studies, they didn't see anything. And then, do we know that are children at risk for severe reactions early on? And interestingly, we personally have looked at this because this was a big issue that we thought about of early introduction. Is a child early on eating a food can be at a greater risk? So we actually looked at it through 2 ways. We actually did a survey of both the United States and the United Kingdom's national health registries. And interestingly, there was no severe anaphylaxis in early children. We also looked at all of our patients who do regular food challenges, and we looked at, can we see severe reactions in our younger children? And we defined severe reactions needing multiple doses of epinephrine or being admitted to the hospital overnight, which really and we didn't see that in the young children. So the infants and the toddlers seem to have less severe reactions than the older children, suggesting that early exposure was not going to cause greater risk, that if anything, early exposure would potentially be beneficial. And this led to some very large clinical trials that have been published over the last several years. And I'm now excited to hand over the talk. We'll be talking about these key clinical trials that have been published through the NIH to Katie Marks, who was a former fellow of ours over in at our institution, and she will be leading the rest of the talk. So thank you.
Thank you so much, Dr. Spergel, and thank you to FAIR. Hi, everyone. Thanks for joining us. So I'll be discussing the clinical studies, the guidelines, and the practical aspects of early allergen introduction. So because of the outcome seen in the observational study on peanut mentioned by Dr. Spergel and other observational studies on the early introduction of foods like egg and milk, researchers designed randomized controlled trials to study this relationship, the relationship between early allergen introduction and food allergy development further. So 3 major randomized controlled trials have really played a large role in influencing the way that we all think about oral tolerance induction and food allergy prevention. And so I'll discuss each one briefly. So I'll begin with the LEAP trial, also called the Learning Early About Peanut Allergy trial, which looked at the early introduction and regular consumption of peanuts into the diets of high-risk infants. So it was a randomized controlled trial of 640 infants in the UK. They were between the ages of 4 to 11 months, and they were high risk, meaning they had severe eczema, egg allergy, or both. They were randomized to the consumption of peanut at least 3 times a week versus the avoidance of peanut until 16 months of age. The infants were skin tested and an oral food challenge was performed if needed prior to starting. The outcome was the diagnosis of peanut allergy at 16 months of age defined by oral food challenge. And the results showed an 81% lower rate of peanut allergy at the age of 16 months in the consumption group. So the conclusion was that the early introduction of peanut, initiated within the first 11 months of life, along with regular ongoing consumption, resulted in a significant reduction in the number of children with peanut allergy compared to those who didn't eat it. So that was very compelling result. I want to point out that while there was a high rate of compliance amongst the participating families, it was reported at about 92%, it did require significant engagement of study personnel with the families. And the thought is because following a protocol like this can be difficult. The LEAP study then had an extension trial called the LEAP On study, and that examined basically the longevity of the impact of early peanut introduction. In this study, children who were exposed to early peanut introduction, who then had a subsequent 12-month avoidance period, continued to show protection against peanut allergy. So this suggests that there is a long-lasting protection from early allergen introduction. The next trial I want to discuss is Petit, which looked at egg introduction into the diets of high-risk infants. Petit was a randomized controlled trial of about 150 infants with eczema. So that means that they were high risk and they were not screened by allergy testing prior to enrollment. They were assigned to early introduction of egg, introduced in a gradual fashion versus placebo for 6 months, plus ongoing eczema treatment. So at 6 months of age, participants in the consumption group were fed a very small amount of heated egg powder that was equivalent to cooked egg. They were fed this daily for 3 months, and then from 9 to 12 months of age, those same participants were fed an increased amount of the heated egg powder. The outcome of this trial was egg allergy at 12 months of age, diagnosed by oral food challenge. And the results showed a 79% reduction in egg allergy prevalence in the consumption group. And so I think it's interesting to note the similarity here, as we just saw an 81% reduction in the peanut study. So the Petit result was a very compelling result and actually prompted them to stop enrollment early because of the significance of the finding. The conclusion was that a combination of gradual introduction of heated egg with ongoing treatment of eczema reduces the risk of onset of egg allergy at 12 months of age. And then lastly, I'll discuss the EAT trial, which looked at multiple allergenic food introduction into diets of infants in the general population. So this was a randomized controlled trial of about 1,300 infants from the general population, so they were not high risk. And they were exclusively breastfed and randomized into 2 groups. The first group was asked to consume 6 allergenic foods starting at 3 months of age, and the second group was asked to exclusively breastfeed with no solid foods until after 6 months of age. The infants in the consumption group were skin tested to all 6 foods, and an oral food challenge was done if needed prior to starting. The 6 foods in the protocol were cow's milk, peanut, egg, sesame, white fish, and wheat. And the outcome was food allergy to 1 or more of these foods between 1 to 3 years of age. So in the intention to treat analysis, there was a non-statistically significant reduction in food allergies. But in the per protocol analysis, so meaning those babies whose families were able to follow the protocol and feed them the foods regularly, there was a significant 67% lower relative risk of food allergy overall in the consumption group. I do like to point out that this trial highlights the difficulty of compliance, and we'll discuss this more shortly, but less than half of the families, so about 43% of the families in this trial, were able to adhere to the protocol because, well, for anyone with experience feeding an infant, you can imagine how hard it is to follow a protocol like this. So there are other studies on early allergen introduction, but these 3 are the most important with regards to influencing guidelines and what we currently recommend for early allergen introduction. So what have we learned from these trials? Well, basically that the early introduction of allergenic foods was safe, with no serious reactions occurring in any of the trials mentioned. And note that all trials included infants that were sensitized to specific allergenic foods already prior to starting. And that the Petit Trial specifically involved high-risk babies that were not screened prior to introduction. In addition, there were no adverse effects on breastfeeding or growth. Specifically, actually, in the EAT trial, the mothers were surveyed and they did not see a decrease in their baby's willingness to breastfeed, those that were in the early consumption group. We also learned that timing really matters. So sensitization to foods can begin very early in infancy, and we know this. And looking at the studies, in Petit, more than a third of the infants were already sensitized by the age of 4 to 5 months, which was their age at enrollment. In LEAP, 9% were actually excluded due to large skin test readings, so meaning they were already likely peanut allergic. And then in EAT, 5% of the 3-month-old children in the early introduction group had a positive skin test response to one of the 6 allergenic foods. We also learned that amount matters. The analysis in the EAT trial showed that a larger quantity per week of the allergenic food was actually associated with a lower prevalence of allergy and sensitization to that food. We also know that we learned that sustaining exposure is really important. So in the studies, infants who were able to comply with the protocols over a multi-month period had greater protection than those who didn't. And we have greater insight into compliance. Unfortunately, we saw, specifically in the E trial, that it's very hard to feed babies multiple allergenic foods multiple times per week for multiple months. Okay. So we just touched on the important landmark trials on early allergen introduction, but now let's look at the chain of events that have basically occurred over the last 4 to 5 years. So the LEAF study results came out at the beginning of 2015, and then the EAT study was published in 2016, and then international guidelines started changing. So you see here that Australia put out guidelines about early allergen exposure or allergen exposure in infancy in 2016. Then later that year, the Petit Trial was published. And then in 2017, the NIH and American Academy of Pediatrics guidelines were published recommending early and sustained peanut introduction. And then the FDA's first ever qualified health claim about food allergy prevention was published, followed by further international guidelines. Here you see societies in the UK and Canada put out guidelines, and we'll look at these more closely in a second. So here's another way to look at the timeline of events, going back even further to address the fact that recommendations have completely reversed from what they were. In the past, it was thought that avoidance of specific foods during the perinatal period and infancy could actually prevent food allergy and eczema. So in 2000, the American Academy of Pediatrics put out guidelines recommending delaying the introduction of milk until 12 months of age, egg until 24 months of age, and peanut and tree nuts until 36 months. Then more data was collected, including, the observational studies we discussed that showed that the early introduction of allergenic food might actually decrease the incidence of food allergies. So in 2008, the AAP reversed their recommendations to delay exposure, and then the NIAID followed in 2010. Since then, the results of the 3 landmark trials that we just discussed supported early and sustained allergen introduction. So the NIH then published their guidelines, and then the FDA's qualified health claim came out. And, this was particularly momentous because it was the first ever qualified health claim by the FDA about food allergy prevention. And then, notably, the recent AAP clinical report was published, which updated and replaced their 2008 report on maternal and infant diet with regard to allergies. So let's delve a little bit further into those guidelines. Basically, this slide shows some of the specific language used in the AAP's 2019 clinical report. So they state that ground peanuts and other infant-safe forms of peanuts may be added to babies' diets after solid foods are tolerated. And so I think this is important because if the allergen is being introduced in the form of solid food, then it's imperative that it be known that the baby can actually tolerate solids. This slide also shows specific language about maternal diet stated in the clinical report, and that there currently is no evidence to support recommending that mom eliminate allergenic foods in her own diet in order to prevent food allergy in her offspring, whether during pregnancy or during breastfeeding. Here we look at the language in the NIH's addendum guidelines on peanut allergy prevention from 2017. So here in the US, infants are first classified into high, moderate, and low risk based on presentation of eczema and or egg allergy. So if your child has severe eczema, egg allergy, or both, then the current recommendation is to have them screened with serum-specific IgE antibody blood test to peanuts or a skin test to peanut. And then based on those results, a decision on how and whether to introduce peanut is made. And then the infants with mild to moderate eczema are recommended to introduce peanut at around 6 months, whereas low-risk infants are recommended to introduce based on family's preferences. This slide shows some key quotes, key excerpts from various international guidelines and guidelines here in the US. And there are some important differences. You'll notice that the international guidelines do not recommend screening with a skin test or a blood test of high-risk children in order to determine how to implement early allergen introduction. Basically, they don't recommend screening all of the high-risk children. Specifically, in Australia, the guidelines recommend introducing multiple allergenic foods such as peanut, egg, dairy, and wheat in the first year of life, including in infants at high risk of allergy. The British Society of Allergy recommends starting egg and peanuts from 4 months of age in babies at higher risk, and more generally, in all babies, they recommend introducing multiple food allergens within the first year of life. The Canadian Pediatric Society notes that early food introduction between 4 to 6 months may prevent food allergy, and they specifically mention peanut and egg. So all 3 international guidelines recommend the early introduction of more than just peanut, and excuse me, and that introducing allergenic foods should be done one at a time. And lastly, here's some more specific language from the AAP's clinical report, basically further acknowledging that the early introduction of peanut may prevent peanut allergy and that there is no evidence that avoidance does any good. So here's another summary slide, and this pinpoints the most important lessons that we've learned, thus far from early allergen introduction. Basically, that it's safe and it's achievable, and it does not affect breastfeeding rates or the nutrition, the later nutrition or growth of children. We've also seen from the trials that it's allergen specific, meaning, for example, the early consumption of peanuts has no effect on the development of other food allergies. The trials also showed us that many children are already sensitized even early on in infancy at 3 to 4 months of age. So that provides, I think that provides some motivation for future trials to look at even earlier windows of introduction. And so because of that, we know that the introduction of allergens into the diet should not be delayed. We also know that allergen exposure needs to be sustained. So, one instance of feeding your baby peanut butter at 4 months of age without continuing is not enough. Sustaining exposure is just as important as introducing it early on. So this slide shows a quote from FAIR, and I think the point here is that anyone can develop a food allergy. You don't have to necessarily be in a high-risk group. We know that over half of children diagnosed with a food allergy do not have a direct family member with food allergy. So this is why it's so important for everyone to do early allergen introduction. So after seeing and hearing about these guidelines, a number of questions naturally arise. So when to start? Is 4 to 6 months early enough? Recommendations currently suggest early infancy because we know that's when babies are we know that's when high-level sensitization is less likely to have occurred. And actually, many in the allergy community feel that 4 months may be too late for some foods and that even earlier is better. But as we know, and we'll discuss further, there are logistical challenges to feeding even a 4-month-old. So then there's the question of what amount to use and how often. Well, we think that there's a critical threshold quantity of protein consumption, and that this is required for the development of oral tolerance. But this may vary per food. And so as an allergist, I see the trials themselves as a guideline for dosing currently. We also ask how long to continue. Some trials use months, while others, used years. So one of the things I tell my patients is, whether they're using a product to help with early allergen introduction or whether they're doing it themselves in a DIY fashion, that they should be scheduling these foods into baby's diet until baby is eating them regularly, as part of their regular diet. But the definition of regular is very broad. So until we have more information, parents, along with their pediatrician, should determine what's right for their baby. And finally, does the effect of early allergen introduction provide a lifetime benefit? Well, Leap On looked at this and continued to follow these children and evaluate this. And so far, the indications are positive. So we've discussed the science, we've discussed the evidence behind early allergen introduction, but now let's get into some of the practical aspects. So what happens on a day-to-day basis and how does this actually work? I think a lot of us envision feeding our babies like the picture on the left, but in my house and probably in many of yours, it's much more like what's happening in this picture on the right. So when I talk to the parents of young children about doing early allergen introduction at home, there are a lot of things to consider. To eat solid foods, baby needs to be developmentally ready. So, questions like, can he or she hold their head up? Can they sit up properly? Have they overcome the tongue thrust reflex? There are many babies 4 months or even 5 months old that may not be ready to eat solid foods. Once they are ready, though, we need to instruct families on infant-safe forms of the key allergenic foods. So safe forms of not only peanut, but other foods like eggs. So, I tell parents they should consider pureeing scrambled eggs with breast milk or formula or even water, for example. I think that frequency is crucial as well, and I tell parents to incorporate these foods into baby's diet at least 3 times per week, which is based on those NIAID guidelines. I strongly encourage families to create a feeding schedule for allergenic foods because it's really hard to keep track of when and how much baby is eating, especially if there's multiple caregivers involved. For parents with a new baby that already has a family member with food allergies, it's important to think about the logistics of early allergen introduction. So, for example, if an older sibling has a food allergy, but the parents want to do early and sustained allergen introduction with their new infant, they need to consider things like the sibling schedule. So they might choose to introduce the allergenic food when the brother or sister is not around, etc. So, in short, the process can be really complex and anxiety-provoking for parents. And I think all of this may sound like a daunting task. There are new products on the market that were created to make it easier. One product focuses on bottle introduction, meaning delivering these allergens mixed into breast milk or formula in a bottle so that babies who aren't developmentally ready to be eating solids won't miss their window of opportunity to possibly develop tolerance to allergenic foods. These products focus on making allergen introduction easier so that it can be easily sustained and so that all families can better comply with the guidelines, in addition to focusing on safety. Now, really, the point of this discussion is not to promote any specific products, but rather I just want to increase awareness about all of the different choices that families have for doing early and sustained allergen introduction, because that's really the most important thing. All families need to explore early allergen introduction because, as we mentioned, every baby is at risk. For anyone that has product-specific questions, I'm happy to discuss these offline if you want to reach out. So on this slide are some of the specifics from the NIH feeding guidelines on early peanut introduction. They provide some ideas on how to feed peanut if you're doing the DIY approach. Obviously, whole peanuts should not be used because it's a choking hazard. So here are some safe forms listed. And it's important to note that the NIAID also has a handout online with instructions for introducing peanut at home that goes into more detail on these forms of peanut, and I think can actually be very helpful for families. So I touched on the evidence and the practicality of early allergen introduction, but I think it's interesting to think about the changes over the last 60 years in terms of the context of the evidence we have now about food allergy prevention. So this slide shows that over the decades, recommendations kept increasing the age for the introduction of allergenic foods, while at the same time, while we saw like a simultaneous increase in the prevalence of food allergies. So you can see here that in the 1960s, the average age was 2 months that infants started eating solids, and that increased to 4 months in the 70s, 6 months in the 90s, and then followed by anywhere from 1 to 3 years in 2000. And this is really a stark contrast to today's guidelines. So where are we headed? Well, I think it's a really exciting time in the world of food allergy and childhood nutrition because we're learning a lot and the science is robust and we have still a lot more to learn. So studies looking at perinatal interventions like diet during pregnancy and breastfeeding. We know that avoiding allergens doesn't help, but what about things like diversity of mom's diet? Can that play a role? What about the role of the environment? More specifically, the hygiene hypothesis and the role of the microbiome. There's evidence suggesting that this plays a role, but not yet enough to precipitate detailed guidelines, so we need more studies looking at this. And there are studies looking at even earlier introduction of allergens to help us hone in on that window of opportunity. And then there are the health nuts and school nuts trials, which are large cohorts of children being followed throughout childhood to help researchers determine the natural history and risk factors for food allergy, which can then help public health policy around food allergy prevention and management. So in conclusion, we know that food allergies become an epidemic in our society. Rates are rising. We have lots more to learn, and thus more research is a necessity. Because there is no true cure for food allergies, prevention is key. There's strong evidence that early and sustained allergen introduction can reduce risk, and this is now broadly accepted and recommended. But unfortunately, there are still a lot of logistical and practical issues that come along with it, and so it's important for healthcare professionals to be prepared to answer the questions associated with that and to be aware of all of the options that can help. So if there's one thing to take away from today's discussion, it's to start early and keep going. Thank you, everyone, for listening. I'll go ahead and turn it back over to the moderator.
Wonderful. Thank you. Thank you both. That was so informative and it's so interesting. And that one of your last slides that we're just talking about the food for thought and the progressive delay over the decades is pretty fascinating. So we've had quite a few questions come through. You answered some along the way, which is really great. But it looks like for everyone out there, we've got about 10 minutes with our presenters. So I will turn it back over to you guys and ask a couple questions. We had a few come in just around introducing allergens and how to introduce. And one of our attendees asked, if someone has not introduced allergens by 6 months, is it too late to see a reduction in risk from introduction? So hoping maybe one of you guys can chime in on that, or both of you.
Sure. This is Dr. Spergel. I'll chime in first and then see if Dr. Marks wants to say anything. The evidence is early, but there's probably a benefit any time before 11 months. So you still can do it after then. the rate really depends probably also on least for in the LEAP trial it was more an issue of how long you had eczema than the age. So I think any time early on and before you have eczema is the key, but the issue is most kids start getting eczema in that 4 to 6 month window, and that's why you wanted to do it early. But you can get some benefit by doing early. If you haven't done it yet, just start, basically.
Yeah, I mean, absolutely agreed. I think, the trials showed that any time, 11 months or earlier is beneficial. But as we know, with increasing age is the possibility of increasing sensitization. So, I recommend exactly the same thing as Jonathan.
Wonderful, thank you. Another question related to introducing allergens. Do either of you know if there is any recommendation around what specific order to introduce the top allergens, if that is even needed, a specific order?
So I can start.
Okay.
So yeah, currently the U.S. guidelines are for peanut. Obviously the international guidelines are for other allergenic foods. I think, I'll just answer what I say in my practice, and I sort of base it off of the most common food allergens in children, which, milk, egg, are the most common, and they can affect quality of life the most. And then, peanuts is also very common and lifelong. And so, I always start with those allergens and then broaden it to tree nuts and, the other top allergenic foods. And again, that's really just, based on experience and sort of trying to triage, the allergens themselves.
This is Dr. Spergel. So there is no recommendation. The U.S. is currently revising, so at least the Academy and the Canadian, so all the allergy societies are coming up with a revised recommendation for the other foods. It's still under review, so I can't say what they are. I know what they are because I helped write them, but can't give you the preview because I'll get in trouble. But the idea is this is true to be consistent with the rest of the guidelines. You want to give the foods early. There's no recommendation of anything late, and a lot of it really depends on the child and the parent. I mean, what you introduce really depends on your personal diet and sort of what you're what the eating in the house. So basically, you want to give the food in no particular order, early if possible.
Great, thank you. And just one quick follow-up to that. Is there a minimum amount of an allergen that should be given?
So that is a little unclear. The studies tend to suggest, at least on the E trial, there is a minimum amount you have to give. So it may not be as true for peanut, but I think it's more of an issue for milk and egg. There is probably a minimum amount because in the E trial, which is when they start doing other foods, it only worked when people ate the minimum amount. So there's probably a minimum amount you do have to give. And I'll let Katie give you the exact amount.
Well, just to piggyback off of what you said, in the E trial, they looked at those dose response curves and saw, 2 grams for peanut and egg. The per protocol group used 3 grams. So I think we have an idea, based off of the data that we have, which is from the trials, on, what the best amounts to recommend right now are.
Great, thank you. Kind of just to jump a little bit, I know this is a question that's come up in the past, And this attendee was asking, are children of food allergic parents more likely to have the same or different food allergies?
So having food allergies, whether in the parent or a sibling, does increase the risk of food allergies in the child. It does not have to be the same food. It can be different foods. But it's not like 100%. It's not like other diseases like sickle cell. When both parents have it, we know what the rate is, or if you have some autosomal dominant disease, it is a multifactorial disease. The numbers aren't that high for the actual rate of kids or siblings with food allergy. It's higher than the general population, maybe twofold, but it's not like tenfold higher.
Great, thank you. We're going to switch gears just real quickly, if you both don't mind, because we're actually getting a lot of questions at the moment are coming in about kind of immunotherapy and desensitizing people who are already allergic, like young kids who are already allergic, and how is immunotherapy different than the introduction we are talking about today. So maybe just one of you could kind of clarify that and just give a quick overview. I'd appreciate it. Thanks.
Sure. So oral immunotherapy, whether it's for peanut, milk, or egg, or sublingual immunotherapy, or epicutaneous immunotherapy, any of these therapies are for treating people who are already allergic. So these individuals already have a food reaction. What we're talking about in an early introduction is the prevention. So we're trying to give people who are not allergic, so they don't have any allergic reactions, giving them the food early to prevent an allergic reaction. So these patients never become allergic, never get hives to food, so they eat it early on. Now, oral immunotherapy, which is basically giving the food early on, so going back to that specific question, is right now being done at many community and some academic centers, and probably will be FDA approved. I cannot read the FDA's mind, but had a positive comments from the preliminary review for peanut powder. And the goal of that peanut powder, just to give you the numbers, in that clinical trial, it was about 60% were able to tolerate a peanut. They're not going to eat more than one peanut, right? What we're talking about prevention is going home to eat a Snickers bar, or eating a bag of peanuts, or having a peanut butter and jelly sandwich. Oral immunotherapy is only letting you eat a single peanut, and that's working in 60%. Prevention is letting people go home and before they have a food allergy, going home and then eating peanut butter jelly every day at school, if you like peanut butter and jelly.
Great, thank you for clarifying. Oh, go ahead.
Oh, no, I was just going to add that the other thing about oral immunotherapy, while it really can, improve quality of life for those that already have a diagnosis of a food allergy, there are still a lot of questions that remain in terms of, does that treatment need to be given, for the rest of a person or child's life? And so there are a lot of sort of unknowns currently. And again, I have a lot of patients ask the difference, and it's really once someone is diagnosed with a food allergy, that's where oral immunotherapy comes into play. But today, what we're discussing is all, prevention, trying to prevent children from becoming sensitized and then going on to actually developing an IgE-mediated food allergy.
Wonderful. Thank you for that addition. Okay, we are almost at time, but if you both don't mind, just one more question. An attendee asked, if a child is allergic to one or two specific nuts, is it recommended to incorporate other nuts as well?
Yes, so so if you're allergic to cashews, you're probably going to be allergic to pistachios, but it doesn't mean you're going to be allergic to almonds and hazelnuts. So each of these fine details is probably good to talk to your individual allergist about. You have to worry a little about issues of cross-contamination, but I know in our practice, if someone's allergic to cashew and pistachios, but not allergic to almonds and hazelnuts, we let them eat almonds and hazelnuts. But probably that fine detail is probably something you need to speak to your allergist about.
Great, thank you. All right. I mean, there's so many more questions, and it's such an interesting topic, so I am so appreciative. Thank you once again to Dr. Spergel and Dr. Marks-Cogan for joining us, and all of you attendees out there. I mean, it really is a new way of thinking about early introduction of foods. And as Dr. Spergel mentioned, and Dr. Marks-Cogan, a good starting place is to speak to your allergist or doctor when it comes to this. So again, thank you. I just wanted to let everyone know that after this webinar, an email will be sent that has a survey. And for those of you listening that are interested in seeking continuing education credits, we have them offered with the Academy of Nutrition and Dietetics. So in the email that goes out will be a link to a SurveyMonkey where you can put your information to get those credits. So thank you both for providing such great information, and for everyone for joining us, and we'll see you again next month. Thanks all.
Thank you.
Thank you.